This is still a continuation of your discussion on the disturbances in external and your middle ear. Our next topic is your acute otitis media. So to talk about acute otitis media, it will be the infection of your middle ear. So acute otitis media is infection of middle ear that may last for less than 6 weeks. Okay, it is common in all ages, but becoming more common among children, particularly those who are less than 12 months of age. Now, what are the risk factors for this type of disease? 1. Tympanic membrane perforation. Later on, we will realize that tympanic membrane perforation is both the cause and the sequelae of this disorder. It is a cause in such a way that once the tympanic membrane is perforated, it gives access to the bacteria gains access, to the middle ear, through the perforated tympanic membrane. Okay? Next, among the causes also is your upper respiratory tract infection, which may also include your rhinosinusitis. And then you also have your allergic reactions. Okay, your URTI, your rhinosinusitis, plus your allergic reactions would lead to eustachian tube dysfunction. Other than that, you also have Down syndrome as a risk factor. Why? Part of your Down syndrome is that there is narrowing of your ear canal. Cleft palate. For your cleft palate class, there is a lack of proper insertion for your tensor villi palatini muscle. Again, that's your tensor villi palatini muscle. So, the lack of the proper insertion of this muscle in the soft palate would lead to the inability of the eustachian tube to open during swallowing or wide mouth opening. So, for that reason, there is a tendency for the pressure to stay inside the middle ear. Okay, then you have your secondhand smoke. Secondhand smoke has been shown as a common risk factor, doubling the risk for your acute otitis media, especially among children. These causative factors or risk factors combined would lead to the entry of the microorganisms to our middle ear. With the entry of the microorganisms to the middle ear, the most common ones are your strep pneumoniae, then you have your H. influenzae, then you have your Moracella catarrhalis. So these are the common causative organism that enters your eustachian tube due to the eustachian tube dysfunction and then going towards your middle ear. Now, a purulent exudate is usually present in the middle ear, and this purulent exudate would later on lead to your conductive hearing loss. So recall that we are still in your middle ear, so problems in your middle ear would still lead to conductive hearing loss. Now, if you will focus yourselves in this diagram, you will see that the presence of the exudate would continue to increase, and then that would also lead to the increase of pressure. Because of the increase of pressure, there will be increased pain on the experience of our patient. So, what will happen? If this will continue, class, once the pressure will continue to increase, okay, meaning class, the fluids inside or the exudates inside your middle ear are pushing against your tympanic membrane, it might lead to spontaneous rupture of your tympanic membrane. So when I say tympanic membrane rupture, usually the patient would say that there is pain relief. Okay, why? What happens? Okay, class, once there is a lot of fluid inside your middle ear, it will compress towards your tympanic membrane, meaning there is still continuous pressure, there is pain, okay, because there is pressure exerted against your tympanic membrane. But once your tympanic membrane has ruptured, your patient might say that there was a popping sound and then suddenly the pain is already relieved. So what's the meaning of that, class? The tympanic membrane already give way, the tympanic membrane already ruptured. Okay, do we want that to happen because it relieves pain? Of course, no. We don't want spontaneous rupture of your tympanic membrane to occur. Okay, because that would lead to the irregularity of the edges of your tympanic membrane once it ruptured. So, what do we do as a procedure for this patient? One is your myringotomy or your tympanotomy. So, class, the aim of your myringotomy and tympanotomy is to provide for drainage. Remember, it's otomy, meaning there's a making of an incision or a hole, and the purpose of that is to provide drainage from your middle ear going towards your outer ear to prevent the spontaneous rupture of your tympanic membrane. Because again, once the tympanic membrane is spontaneously ruptured, it would have irregular edges. It will be more difficult to repair. Unlike in your tympanotomy and your myringotomy, that wherein it can heal in its own. Okay? Now, once class your acute otitis media is not treated promptly, The severe complications would include your meningitis, then your brain abscess. So class, when I say brain abscess, that's the presence of pus deposits in your brain tissues. Then you have your permanent hearing loss. Okay, that's why even some will say, oh, it's just otitis. Okay, class, otitis media is a serious concern. It needs to be managed. So, other than that, class, since we're talking about infection, we're giving your patient broad-spectrum antibiotics. So, class, in your broad-spectrum antibiotics, it is both otic, okay, meaning locally applied, and then you also have your systemic antibiotics. Okay, because your otitis is difficult to treat, you need to have combination of local and then systemic antibiotics. So, when I say systemic antibiotics, that may be given intravenously or that may be given per orim, depending on the condition of your patient. Okay, class, so this is how the bulging of your tympanic membrane would look like. So if you can recall, no, this is our discussion earlier, okay, or on the previous lectures, which would say that the landmarks of the tympanic membrane can be easily seen. Whereas, class, if your tympanic membrane is already bulging, okay, you can see that the landmarks are already gone. Okay, you could not see where is your pars flaccida, pars tensa, and then you could not even see the part of your malleolus because there is bulging of your tympanic membrane. So once this tympanic membrane, class, or this type of tympanic membrane here on the right, okay, is seen during otoscopic examination, you would suspect that your patient would already be in pain. Okay, then again, as I have mentioned, once the pain is suddenly gone after a popping sound, you would suspect tympanic membrane rupture. Now, just as a comparison of your acute otitis externa and then your acute otitis media, this is actually an image retrieved online, which is a reference from your textbook. So, class, when I talk about acute otitis externa and media, so presence of otorrhea. So, otorrhea is discharges. It may be or may not be present in externa. However, class, in media, it is just present once the membrane has already perforated. And then the discharge will be profuse. Because imagine, there's a lot of pressure there. It has been holding on for long there. It's waiting to be released. Okay? Once it's released, class, once it's released, the tendency is that it becomes profuse. Next, otalgia. Class, your otalgia, your pain will be persistent in your otitis externa. It has a tendency to awaken your patient at night. On your acute otitis media, class, your acute otitis media pain would be relieved if the tympanic membrane would rupture, which is not actually a good indication. Next, oral tenderness. When I say, class, oral tenderness, I'm talking about your pinna. Of course, class, it's present in your acute otitis media, but it's absent in your, oral tenderness is present on your otitis externa, and it is absent, usually absent in your acute otitis media. That's why earlier recall that I have said that once your patient would have otitis externa, the tendency is that when you will be touching, class, the auricle, they will also be in pain, okay, because of the presence of your tenderness, okay, which would also involve your external auditory canal. Systemic symptoms are expected to be absent in otitis externa because remember, external ear, it's separated from the middle ear by your tympanic membrane. However, class, in your acute otitis media, there is usually involvement of fever, upper respiratory infection, and then your rhinitis. If you can recall, these are actually causative, okay, or risk factors that increases our risk for otitis media. Edema of the external auditory canal. There will, of course, be edema if I'm talking about acute otitis externa. Okay, but in media, the external ear canal could be safe. Okay, I mean, there's no problem with the external ear canal. So, edema tends to be absent. Tympanic membrane. In your acute otitis externa, it may appear normal because it's not involved in the infection. Whereas in your acute otitis media, the tendency is that your tympanic membrane has presence of erythema. Your tympanic membrane may be bulging, okay, and may be perforated. And then on the type of hearing loss, since we are both dealing here with external and middle ear, okay, it would be the same type of hearing loss, which is your conductive hearing loss. Okay, so recall conductive hearing loss for your external and middle ear, sensorineural hearing loss if we're talking about your inner ear. Now we have been talking about the procedure myringotomy or tympanotomy. So how is it actually done? So prior to the procedure, you need to prepare for the following. Local anesthesia is used, such as your phenol. and then iontophoresis or iontophoresis is done. So iontophoresis will be done during the procedure. When I say iontophoresis, it is an application of electrical current that would flow through lidocaine and epinephrine solution, and the purpose of which is to numb the ear canal and the tympanic membrane. So class, again, the purpose of your iontophoresis is to ensure that the ear canal and the tympanic membrane will be numbed during the procedure. So we educate our patient that the procedure is usually painless. Okay, class, if it's painful, meaning there's something wrong on the anesthesia applied to the patient. The procedure is only expected to last for 15 minutes, but after which we would orient the patient that the healing would take about for 24 to 72 hours. Okay, class, if your patient would have recurring acute otitis media, what can be done as a part of management is the provision of your ventilating pressure equalizing tube. Okay, class, the ventilating pressure equalizing tube may be left in place for 6 to 18 months. So if you would look at, class, the picture on this background, you can see that this is actually your tympanic membrane, class, wherein tympanotomy was done. Okay, and the purple one here is actually your pressure equalizing tube. Okay, again, the purpose of that is obviously to equalize the pressure between your outer ear and then your middle ear, and typically to reduce the pressure, class, in your middle ear. Okay, because the problem in your acute otitis media is the increase in the pressure from your middle ear. Now, you have your chronic otitis media. So the term implies chronic. So this is the result of recurrent acute otitis media causing irreversible tissue pathology and persistent perforation of your tympanic membrane. Okay, class, your concern here is the presence of irreversible tissue pathology. Okay, class, this is a result of the damage. Its sequelae or its effect could result to damage of your tympanic membrane, the destruction of your MIS, okay, your malleus, your incus, and stapes, and even, class, damage to your mastoid. Okay, it may lead to mastoiditis, which is a serious infection. What are the signs and symptoms? Class, your patient would have hearing loss, conductive hearing loss again. Okay, class, there will be a foul-smelling otorrhea, foul-smelling discharges from your patient's ear. Class, pain is usually negative, meaning pain is absent except if your patient is already having mastoiditis. There will be post-auricular tenderness, there will be erythema, and there will be edema. Perforation or cholesteatoma may be present, class, once you do the otoscopic examination of your middle ear. So what is our management for this patient? Suctioning may be done, but suctioning needs to be done with caution. Antibiotic drops and antibiotic powder may be applied, and then, class, systemic IV antibiotics is given for acute forms of this disease. Okay, but usually, since this is chronic otitis media, class, it is difficult to treat with just single type of antibiotic, so combination of antibiotics and combination of routes are usually employed. Now, we've talked about the term cholesteatoma. So what do I mean by cholesteatoma? Class, your cholesteatoma is actually your white mass behind your eardrum. So how did it occur? Class, your cholesteatoma may actually be a result of your high negative pressure or chronic retraction pocket. Okay, meaning, class, chronic infection or chronic inflammation of your middle ear. Okay, this would lead to a tumor of eardrum into the middle ear that would appear, class, as a white mass behind your eardrum. Now, this white mass is again referred to as your cholesteatoma. Okay, cholesteatoma may actually be present as a birth defect. It could be, class, the presence of your cyst or sac that sheds layer of old skin. Class, your cholesteatoma may actually be asymptomatic and usually found only during otoscopic examination as an incidental finding. However, okay, if it will lead already to the compression of your cranial nerve number 7, you may experience facial pain and paralysis. And this one, class, is usually diagnosed using your CT scan. So it needs to be removed once your patient has already become asymptomatic. Once your patient has become symptomatic with presence of symptoms. So what is the surgical management for your chronic otitis media? Okay? One thing, class, that could be done is what you refer to as your Tympanoplasty. So, class, if there is if there is rupture, if there is spontaneous rupture of your tympanic membrane, it needs to be repaired. It's referred to as your Tympanoplasty. So, class, when I say Tympanoplasty, okay, this is the surgical reconstruction of your tympanic membrane. Okay, a surgical reconstruction to your tympanic membrane. Class, there are actually 5 types. Okay, we refer to this classification as your Wolstein classification. So, Wolstein classification says type 1, repair of the eardrum. Type 2 would involve grafting to the incus and remains of the malleus. Type 3 will be grafting to the stapes, whereas type 4 is grafting to footplate of the stapes, and then type 5 is your footplate repair. Class, footplate is part of your stapes. Now, Osseculoplasty. When I talk about your Osseculoplasty class, this refers to the surgical reconstruction of the middle ear bones to restore hearing. Okay, that is with the use of your prosthesis made of materials such as your Teflon. Okay, prosthesis using your Teflon, may use your stainless steel, and then we may also use your hydroxyapatite. Okay, now on the picture, class, you can see there the prosthesis that is being used for your middle ear bones. Okay, so you have your PORP and then you have your TORP. Class, your PORP stands for partial ossicular replacement prosthesis, whereas your TORP stands for total ossicular replacement prosthesis. So again, total ossicular replacement prosthesis, a replacement for your ossicles. So these are already commercially available. In severe cases wherein there is already involvement of your mastoid process, okay, in other words, there is mastoiditis, mastoidectomy may need to be done. Now, during your mastoidectomy, the procedure would usually involve a post-auricular incision. So when we say post-auricular incision, that is an incision done here, behind your ear. Now, after this procedure, would expect the dressing to be intact, okay, or dressing should be in place, particularly in the first 24 to 48 hours. You need to watch out for any signs and symptoms on the face of your patient. Once there is facial paresis, once there is facial weakness, we would suspect involvement or accidental injury to cranial nerve number 7 during the surgery. So it needs to be referred back to the surgeon, your otolaryngologist on that matter. Okay, so class, if you can see, this would illustrate your mastoiditis. So in your mastoiditis, there is presence of infection, and then class, the ear would be turned forward because of the presence of the swollen area behind your ear. So again, because of the presence of the swollen area behind the ear, class, okay, the ear would be turned forward. Now, this image would show to us how mastoidectomy is done. Okay, so class, this is a post-auricular incision. Okay, so again, mastoidectomy here is done because of the presence of mastoiditis as a complication of your chronic otitis media. Now, post-op care for a patient post-mastoidectomy. First, okay, wicking or external auditory canal packing needs to be done. This packing would involve your antibiotics. After the surgery, it is expected that your patient would have sharp shooting intermittent pains. Okay, these sharp shooting intermittent pains would last for 2 to 3 weeks because this is your eustachian tube opening and allowing air to enter. And you'd be expecting serosanguinous secretions. So when we say serosanguinous, that's the mixture class of your secretions from your plasma and then your blood. But your patient would need to report constant throbbing pain plus fever, okay, because that would indicate infection on the site. Incision site must be kept dry for 2 days, and then class, vertigo should need to be monitored. We watch out for vertigo. We orient our patient that vertigo may occur while the healing process is still going on, and then class, no water or no swimming for 6 weeks, okay, or as advised by the physician. Okay, class, because your swimming would also increase the risk for the recurrence of infection. Okay, so class, wicking, we've discussed about wicking. So these are class your wicks, your external auditory canal wicks. Okay, so as you can see, before hydration, after hydration, okay, as you can see, there is enlargement of the wick. Okay, so class, the size that is being inserted will be smaller, but once you apply the medication, it has a tendency to go bigger as it absorbs your medication. So again, the purpose of your wicking is to facilitate the application of the medication and to ensure that it stays where it should be. Now, still part of the post-op care for mastoidectomy, you need to ensure that your patient will not be lifting heavy weights, and that will be not greater than 10 pounds. Okay, which should stop or prevent straining, exertion, nose blowing for 2 to 3 weeks because that might lead to dislodgement. Okay, now report drooping, slurred speech, decreased sensation, and dysphagia. Okay, class, drooping of your face, the slurred speech, decreased sensation, and dysphagia are signs of cranial nerve number 7 damage. Then, we need to check for the taste disturbance and dry mouth on the side of the surgery. Why? This could indicate damage to the chorda tympani nerve. Okay, there might be a damage on your chorda tympani nerve. Next, we have your serous otitis media. So class, your serous otitis media is another disorder. Okay, class, serous otitis media, also known as your middle ear effusion. This is the presence of the fluid without the evidence of infection. There is no infection here. This is brought about by the negative pressure due to the eustachian tube obstruction. Okay? Now, supposedly, if there is presence of fluid there, that could be drained going towards our eustachian tube. But since in this disorder class, what might have happened is that the eustachian tube is obstructed. And because of that, what actually happens is that there is presence of fluid without evidence of infection. Next, so what are the risk factors? You have your radiotherapy. Okay, your patient who are on barotrauma. So class, barotrauma, trauma related to pressure. So those are your patients who have had, for example, doing scuba diving, okay, who are on extreme pressure. Maybe your astronauts for that matter. Then you have your URTI, upper respiratory tract infection, the presence class of your allergy, and then the presence of carcinoma. An example of which is your nasopharyngeal cancer. So what are the signs and symptoms associated with your serous otitis media? Class, it would include your hearing loss, your fullness, popping and crackling sound as the eustachian tube would attempt to open. The tympanic membrane would appear dull because there is a tendency for the buildup of pressure resulting to the bulging of your tympanic membrane. And there could be presence of your air bubbles. Okay, so class, this is just a structure of our ear just to remind us where your serous otitis media may be accumulating. So again, it's just like your otitis media, your acute and chronic otitis media. But this time in your serous otitis media, it's just all fluids. We're not talking here about infection. So what is our management for this type of patient? It is not treated unless infection will progress. Okay, if your patient is having hearing loss already, myringotomy may be done. Okay, class, meaning there is conductive hearing loss due to the buildup of the fluids. We can do your myringotomy or your tympanotomy to release the serous or the fluid from the middle ear. Corticosteroids may be given to decrease the inflammation. Okay, the use of your decongestants for your serous otitis media was not having a proven effect. And then class, Valsalva maneuver with caution may be done. Okay, so class, your Valsalva maneuver could possibly aid on the opening of your eustachian tube. Okay, but that will be done class under the supervision of your physician because we are not sure if indeed your Valsalva will be able to open your eustachian tube, because if not, it will just be able to aggravate the condition of your patient. Next class, you have your tympanic membrane perforation. Okay, so the tympanic membrane perforation here class is the spontaneous rupture of your tympanic membrane. Okay, I've talked about this in your acute otitis media. Now, etiology may be infections such as your otitis, maybe trauma, skull fracture, explosion, direct blow, perforation using your cotton and your hairpin. Assessment, your patient would manifest with otorrhea or rhinorrhea. Okay, class, you might be asking why rhinorrhea. Class, your rhinorrhea there, okay, secretions through the nose, would be evident if you're talking about your skull fracture and then your head trauma, wherein both the ears and the nose may be involved. So what is our management? Okay, class, for the spontaneous rupture of your tympanic membrane, okay, it may not be managed if it can be spontaneously healed. Okay, because class, spontaneous healing may occur. Whereas if it's not, so you can have your Tympanoplasty, and we are using your temporalis fascia. Okay, class, we are using your temporalis fascia for this. Okay, so when we say Tympanoplasty, plasty is repair, so this time it's the repair of your tympanic membrane. Okay, so class, this is how your normal tympanic membrane would look like. And this is how your tympanic membrane who have had a rupture would look like. Okay, this is class the source of the muscle, so the temporalis fascia, which is used to put a patch on your tympanic membrane. In other words, to perform Tympanoplasty. Class, so Tympanoplasty or myringoplasty. So as you can see, muscle will be taken here, and then this hole will be covered up, okay, with that muscle. Now, class, your mastoiditis. So when I talk about your mastoiditis, class, your mastoiditis is actually the bacterial infection of your mastoid antrum and the air cells. Okay, so it's the antrum part of your mastoid bone. What are the causes? Chronic otitis media, and then at times you have your acute otitis media. Okay, but oftentimes it will be chronic, of course. So what is the assessment finding for this patient? There will be dull ache and tenderness in the area of the mastoid, low-grade fever, malaise and anorexia. So you're having systemic symptoms. Then you'll have thick purulent discharge that gradually becomes profuse. Then there will be presence of post-auricular erythema and edema, which would result to your conductive hearing loss. And then there's also edema of your tympanic membrane. Okay, just remember, class, that you'll have signs and symptoms of your chronic otitis media in addition to the signs and symptoms of the inflammation of your mastoid. Class, if you look at this picture, there is already dull ache and tenderness in the area of your mastoid process. Of course, class, what you can see is the inflammation. Okay, so what is our management for this patient? Class, these patients are usually managed with your parenteral IV antibiotic, and then your myringotomy is done. Okay, and then you will have your simple mastoidectomy with Tympanoplasty. So class, what is being done here is that there is a removal of the mastoid bone and the infected tissues for the purpose of control of infection. Because once your bone infection, class, is not treated, it has a possibility to progress. Okay, so complications, that is for you to watch out on the functioning of cranial nerve number 6 and cranial nerve number 7. Okay, so try to recall if what are the indications of abnormalities, or what are the assessment findings, that would indicate that there is damage on your cranial nerve number 6 and cranial nerve number 7. Plus, looking at the picture, you can see acute mastoiditis and you have your chronic mastoiditis, okay, which is brought about by acute otitis media, and then you have your chronic otitis media. Okay, notice here, class, there is already presence of scarring. Okay, the white substance there may already be your cholesteatoma. Okay, so what are the complications for your mastoiditis? Okay, so class, cranial nerve number 6 and 7 damage would be indicated by, if your patient, class, is unable to look laterally, there is a damage already to your abducens, cranial nerve number 6. And class, once your patient would have drooping of the mouth on the affected side, there is already damage in your cranial nerve number 7, your facial nerve. Okay, class, worse, your patient may have vertigo, meningitis, brain abscess, and chronic purulent otitis media, and then also presence of wound infection. Class, these patients would have the nursing diagnosis of acute pain related to the inflammatory process, chronic pain if we're dealing with chronic otitis media, although pain may be an indication already of mastoiditis. Then you have your activity intolerance related to the pain, and then sensory perceptual alteration. In this case, class, it will be auditory alterations. Now, let's discuss your otosclerosis. So class, when I talk about otosclerosis, your otosclerosis is defined as the hardening of the bone. Okay, what happens here is that the abnormal sponge-like bone growth in the middle ear. Okay, there is abnormal sponge-like bone growth in the middle ear, or your stapes. Okay, class, recall that your middle ear would have the 3 bones, malleus, incus, and stapes. Okay, would just like to grab this opportunity to tell you that, or to remind you that these 3 bones, malleus, incus, and stapes, are also known as your hammer, okay, your anvil, and then your stirrups. Okay, so hammer, anvil, and then your stirrups. If you look at the structure, I think you'll be able to relate. Okay, and then class, those names would also be able to relate to their function. So what happens here in otosclerosis is that there is hardening of your hammer, anvil, stirrups. Okay, other than hardening, there is sponge-like growth in the middle ear, okay, particularly in your stapes. Now, if you would look at this diagram, this would remind us of the problem that might happen in your patient with otosclerosis. So otosclerosis has a genetic implication. Okay, it's common among young adults and then more common among female. So what happens here is that there is formation of the new abnormal spongy bone, okay, which would lead to the fixation of your stapes. So class, usually it is the stapes which is affected. This would result to ineffective sound transmission, and since part of middle ear will have your conductive hearing loss, there is a possibility for mixed hearing loss. Okay, later on, if this is not managed, the complications would involve your complete deafness. Then you will have your nerve damage, and then infection, dizziness, pain, and even your bleeding. Okay, so these are the complications. Now, why is our patient having class your complete deafness? Class, the complete deafness there is due to the scar tissue infection or blood vessel spasm. Okay, nerve damage. Class, your nerve damage is brought about by facial weakness, which is due to your swelling and your facial paralysis. And then you have your infection, dizziness, pain, or blood clot in the ear, which are consequences, of course, of your surgery. Okay, and that is, class, the surgeries that are being done is your Mastoidectomy and then your Mastoidotomy. Okay, now let's try to talk about those surgeries before I proceed to the nursing diagnosis. By the way, signs and symptoms first. So class, for your otosclerosis, since this is genetic, okay, this is systemic, okay, you would have both ears affected. So first, usually the first ear would progress first. So class, you'll have unilateral to bilateral hearing loss. Okay, there will be presence of tinnitus, okay, ringing of the ears. There is what we call your paracusis of Willis. Class, when I talk about paracusis of Willis, this is classic to your otosclerosis. Okay, paracusis of Willis. Your patient is able to hear conversation better in a noisy environment than in a quiet one. Okay, then class, there will be stapes fixation, okay, which would lead, class, to prevention of the normal transmission of sound from the eardrum going towards your inner ear. Okay, again, because of the fixation of your stapes, class A fixation, it could not move, it would lead to, it would stop the normal transmission of sound from the eardrum into the inner ear. Okay, then you have your tympanic membrane. The tympanic membrane would usually appear to be normal. You don't have a problem with that because the problem is usually on stapes, and then in your tympanic membrane, it is your malleus that you can easily visualize. Okay, recall the protrusion there, that is your malleus. The Renate test would have bone conduction longer than your air conduction, and then the audiogram will be showing your conductive hearing loss. Okay, now, what are our management for this patient? Since we're dealing about bones, we're thinking about fluoride. Okay, we're thinking about calcium and then vitamin D, which could possibly help our bones. Okay, the proper process of bone development. So you have your Mastoidectomy and then your Mastoidotomy. So class, in your Mastoidectomy, the stapes are being removed and replaced with prosthesis. And then in your Mastoidotomy, okay, a hole is drilled, or a laser is used to make a hole, and then use the stapes to hold your prosthesis. Okay, take note of that. Now, post-operatively, we need to educate our patient that he must not blow the nose for 1 week after surgery. She needs to avoid people with respiratory or other infections because that might be transmitted to her. She needs to avoid bending, lifting, or straining. And then avoid loud noises or sudden pressure changes such as your scuba diving, flying, or driving in the mountain. Okay, or else the condition would progress. Okay, so class, the complications again. So you have your complete deafness, nerve damage, then infection, dizziness, pain, and blood clots. With this, the common nursing diagnosis for this patient is your sensory perceptual auditory problem related to the changes, of course, in the bony structures of your ear, social isolation related to inability to communicate, ineffective individual coping related to prolonged period of perceptual changes without diagnosis, impaired verbal communication because of the reduced hearing, and then fear related to possible permanent hearing loss. Okay, permanent hearing loss is common in otosclerosis. Then class, you have the term Tympanosclerosis. Okay, earlier it's otosclerosis, so the problem in otosclerosis is your 3 ossicles. Okay, they become sclerosed, they harden up. Now class, in your Tympanosclerosis or your myringosclerosis, as the term implies tympano, so this is calcification of the tissues class in your middle ear, or the division of your middle ear and outer ear, and that will be your tympanic membrane. Okay, assessment findings for this patient would include a hearing loss and then chalky white patches on the middle ear or the temporal bone. So class, in this case, you can see that this is the normal eardrum, and then here you can see scarring. Okay, so there is scarring of your tympanic membrane. That's your tympanosclerosis. So what is being done for a patient with tympanosclerosis or myringosclerosis? By the way, what's the reason for this? Class, this is actually your tympanic membrane healing. Okay, this is your tympanic membrane which is healing from spontaneous rupture or from surgery also. Okay, however, the healing process is not very good. That's why it leads to scarring. Okay, now class, management for this, the use of your hearing aid. Or surgery needs to be done wherein the sclerosed areas need to be excised, and then the entire ossicular chain will also need to be repaired. Because class, if your patients would have tympanosclerosis, the tendency is that they also have autosclerosis. So from the tympanic membrane going towards the ossicles, it needs to be repaired. What is the complication for this? Your patient may have sensory neural deafness or hearing loss. Okay, that is because to the damage to the inner ear brought about by the surgery. Okay, it's a possible serious concern. Okay, class, the surgery is very delicate. That may also lead to hearing loss. On the next discussion, we'll be talking about the conditions of the inner ear. Once again, reminding you to laugh a little louder and to dream a little bigger. Thank you for your attention.